Welcome to Live Doctors. Our program today is on asthma. I am your host for the program. My name is Dr. Kent Barchov. It's our privilege to be here with a specialist in allergy medicine, Dr. Stanley Feinman. Dr. Feinman, welcome to the program.
Thank you. Thanks for having me.
Dr. Feinman received his specialty training in allergy medicine, allergy disorders, through Harvard Medical School. Dr. Feinman, could you please give us a definition of what asthma is?
Well, asthma is an inflammatory disease that affects the airways. So when patients are suffering from asthma, which is usually triggered by an allergic problem, an allergic trigger, then what happens is that the airways are inflamed and they become twitchy, and they tend to close when they're exposed to the triggers, which include the allergies. When they close down, then people have trouble breathing. So when you have trouble breathing, then you get symptoms like coughing, like shortness of breath, wheezing, and those are some of the symptoms that you get from asthma.
And you as a doctor, when you examine a patient with asthma, what do you find on the physical examination?
Well, first thing we do when we talk to patients with asthma is to find out what their symptoms are and what tends to trigger them. So the first thing is the history. The history that we get from the patient is very important. Some patients have their asthma triggered when they're running or doing activity. Some patients have their asthma triggered when they're infections, like have a respiratory infection or a cold. Some patients it's triggered by an allergen like their dog or a pet that they're exposed to, or smoke. A lot of people are triggered by smoke. So it depends on what's triggering their asthma. The other thing that's important about asthma is that it can be a hereditary condition. So frequently, a patient who has asthma, their parents or their siblings might also have asthma or other allergy type conditions. So those are some of the things we look at first. The next thing, when we start to examine a patient, besides looking for signs of allergy, and a lot of times we'll see things like nasal congestion or allergic nasal disease, but then you listen to the lungs. So we use a stethoscope to listen to their breathing, to see the breathing pattern, and also to hear, sometimes we'll hear wheezing. Wheezing is usually a sign that the airways are closing. And when the airways close down, which is typical of asthma, then you get the whistle noise of a wheeze. And that's where we hear wheezing in asthma.
Would you please comment also, what is lung function test or pulmonary function tests?
Well, when we evaluate somebody for asthma or for breathing difficulty, besides the history, which we talked about, besides the physical exam, which we're going to listen for things like wheezing and shortness of breath, then we do other things to try to evaluate how their breathing is. The lung function test, or the spirometry, is a very, very useful tool which should be done on everybody who has asthma that can do the test, because it's not an easy test to do. We basically take the patient and they blow into a machine, and it measures the amount of capacity that they have, how much air that they're really blowing out, and how fast they blow out. And through that, we can calculate the obstruction of the airways, how much they're closing down. And of course, when we give them medication like a bronchodilator, then they reverse and the airways opened up. So asthma is really a reversible airway obstruction. So you're asking me the definition of asthma. It is really a reversible airway obstruction related to inflammation and exposure to allergens.
What is the role of a chest x-ray in evaluating someone with asthma?
Well, a chest x-ray is really a tool that we use to evaluate the condition of the lung, and it just shows us a picture of what's happening in the lung. We don't get one on everybody who has asthma. We frequently, in pediatric asthma, when it's reversible and we can get a normal lung function, we may not get a chest x-ray. In an adult who has a persistent cough or a chronic cough condition, it's probably a useful tool to get a chest x-ray to make sure you're not missing something, that there might be something else going on. So basically, we use a chest x-ray as a tool to see if there's something besides asthma that's there, because asthma does not show up on a chest x-ray.
And what are the role of blood tests in asthma?
Well, we don't usually do very many blood tests in asthma. Since it's a respiratory condition, we're really more concerned about the lungs, the lung function. One of the new tools that we're using recently is called an exhaled nitric oxide. Now, exhaled nitric oxide is a new technology that measures the inflammation of the airway. So patients can blow into this device. We measure the amount of this exhaled nitric oxide and basically measure how much inflammation they have. So based on the level, we can tell whether or not the patient's in control. So one of the main things that we do as asthma specialists is to make sure that our patients' asthma is in control, which means their lungs are open, that they're breathing normally, and they don't have any lung problem or they don't have any breathing problem related to their asthma. So that's really our goal. So it's really control their asthma control, and that's our main purpose. So we don't really do blood tests. We may want to do allergy tests, skin tests, to find out what their what some of their triggers are. If they have a pet exposure, if they get worse during pollen seasons, we may want to do testing to find out, do they have an allergy to the pollen? Do they have an allergy to their pet? Things like that. So those are the kinds of tools that we really use to evaluate, the asthma function with the lung function, the inflammation, which is the exhaled nitric oxide, and then some of the triggers by doing allergy testing.
We've been speaking with Dr. Feynman about the diagnosis of asthma. Now we'd like to turn to treatment. Once you've determined that someone is suffering from asthma, what is the next step? How do you help this person?
Well, first we find out how severe their asthma is. So we classify the asthma intermittent, which means they may not have it all the time, mild, moderate, and severe. So a patient with severe asthma is going to have symptoms every day. They're going to be relatively sick, having a lot of trouble breathing, and they're going to need a lot more intensive therapy than somebody who has mild asthma. A mild asthmatic may have persistent symptoms. They may have coughing, trouble breathing when they're doing activity and things like that, but they may not be having active wheezing symptoms on a daily basis. So I think it really depends on the severity of the asthma. So based on the classification, and we call the mild, moderate, severe, that's the asthma classification, then we determine what therapy. And we have guidelines. The National Institute of Health has some very good guidelines on asthma treatment, and basically they point out that we should direct the therapy at the severity or the classification and try to make sure they're in control. So we start with a lower therapy for somebody with mild asthma, in other words, fewer drugs, and then step up. It's called a step-up therapy. So we step up the therapy in somebody who has severe asthma, and we give them more medications to try to help get them in control. So the first thing we would do is have a bronchodilator. So the bronchodilator therapy opens the airways. It's a very effective tool. It usually works quickly, and we have all asthmatics have a bronchodilator, which we call a reliever. So it's usually an inhaler that they can use. It's a quick reliever, and then whenever they have a flare-up, they can use that. So that's their kind of relieving, or sometimes people call it a rescue inhaler. That's kind of a basic for everybody. So an intermittent asthmatic might just use it once a month or twice a month. Somebody with severe asthma may need it every day. So it just depends. So let's say somebody who has asthma, and they're using their rescue inhaler, their bronchodilator, more than 2 times a week. So if you're needing it more than 2 times a week, that means your asthma is probably not very well controlled. So in somebody who's not well controlled, then we call it persistent asthma. That's when you need to use a daily controlling medication. The best daily controlling medication is an inhaled steroid. So the next thing we would go to would be an inhaled steroid. Now, inhaled steroids are very good medications. They are corticosteroids, which means they help control inflammation, but they're inhaled, and so they work right in the lung, reducing the amount of side effects. And so we really monitor patients for that, but it's a relatively safe type therapy when we use it at the proper dose and people are monitored. So that would be a mild persistent asthmatic. And then if you have somebody who's not controlled with that and still needing their rescue inhaler, their albuterol, then we start adding more treatment on. Some of the treatment we might use would be a long-acting bronchodilator. And there are medications that combine the inhaled steroid with the long-acting medication into one inhaler. We call those combination inhalers. Sometimes we'll use a pill called a leukotriene antagonist, like montelukast. That's another medication that sometimes we'll add on to the controlling medication. And those are basically the main tools we would use, and it depends on the severity. If you have somebody who has more severe asthma, then you might have to use additional type medications.
We've been talking with Dr. Feynman now about treatment. Now we'd like to move to prevalence, or what age groups have the condition of asthma. What is the earliest age that someone could be diagnosed with asthma?
We've seen young children, with asthma. Now, in infancy, when you have recurrent respiratory illnesses and you're very young, let's say toddler age, we don't like to label them as asthma. Frequently, we'll call it reactive airway disease. And we treat it the same way, and a lot of them do develop asthma. Probably at least 20% can develop asthma. So in the infants and the toddlers that have recurrent wheezing or respiratory illnesses, we call that reactive airway disease. And reactive airway disease, we treat the same way we do asthma, but sometimes we may not label them asthma because a lot of times children may grow out of that condition. But at least 20% will have persistent reactive airway disease, which then we call asthma. And one of the things we like to do, of course, is measure lung function, which you cannot do if you're under 5 years old. So under 5, it's a lot more difficult to make the diagnosis, but you have to make sure you use a clinical guidelines. In other words, the symptoms, like the symptoms of the cough, the wheezing, the recurrent illnesses, and that really helps us to determine what the diagnosis is in those types of patients.
Can someone who is an adult who did not have asthma as a child, can they develop asthma as an adult?
People do develop asthma as adults, and this is something that I have patients who come to me and they're adults and they say, well, I've never had asthma before, and they come in and they have symptoms of coughing, they're wheezing, they have shortness of breath, and they basically have asthma. And we do the lung functions and we see they have reversible lung obstruction, and they don't understand it. Well, a lot of these people have allergies as well. So allergies predispose to asthma. And that's one of the things that we really see a correlation. So when somebody, let's say, had allergies or hay fever when they were a young child, they may be at higher risk of developing asthma as they got older. So there are certain predisposing factors that could contribute to the likelihood that they're going to get asthma, but it just really varies. And so it's really any age.
So Dr. Feynman, would you please talk about the environmental aspects and who is at risk for asthma?
So the main problem that we see with the environment is things like pollution, smoke, and exposure to animals. Those are some of the biggest risk factors that somebody has who has asthma. So we try to encourage them to keep their exposure to animals at a minimum, stay away from smoke. Certainly they shouldn't be smoking, and even secondhand smoke can make patients' patients who have asthma can make their lungs have more trouble with their breathing. So stay away from secondhand smoke. And then we're seeing more and more a problem with pollution. So now, since we see so many cars on the road, that sometimes the pollutants from the automobile exhaust can also aggravate people who have asthma. One of the problems we have where I live, which is in Atlanta, which is a warm climate, is that sometimes we'll have heat waves, and the heat waves in the summer can sometimes cause a smog problem. Smog is a condition where the air is relatively stagnant, and a lot of these pollutants stay in the air. And so we have things what we call orange alerts or red alerts, where there's so much smog in the air that patients who have asthma, when they go outside, it can really cause more trouble with their breathing. So those are some of the things that we see as risk factors for patients who have asthma.
What are the conditions that are missed, meaning someone comes to the doctor for one problem and for whatever reason there is a slow diagnosis of asthma? How does that happen?
Well, asthma is a reversible airway obstruction. So in a condition that's a reversible airway obstruction, the patient may not have symptoms all the time. So Sometimes they may feel well, sometimes they might have symptoms. It just really varies with each person. So it's not an easy diagnosis to make. And so you really have to use all the tools. You have to get the good history, find out from the patient what's happening with them. Number two, you have to do the right tests like a lung function, which is critical to determine what the condition of their airways and their breathing is. Maybe use an exhale nitric oxide, and then use some medication and see how they respond to it. So it's sometimes not such an easy diagnosis to make. There are other conditions that can kind of mimic asthma. You could get airway obstruction from an aspiration. I had a patient once who was eating a salad, and there were nuts in the salad, and they choked on the salad. And the next thing I know, they come to me about a month or two later, and they're having symptoms of coughing and wheezing, and they were diagnosed with asthma. Well, they were given medication, but they weren't getting better, and they were wheezing. And then that's when the chest x-ray came in, because we did the chest x-ray and realized that there was a problem in the lung. It wasn't just asthma. And then at that point, we realized that they must have aspirated something there. And so we had to get a pulmonologist at that point who was able to go down into their lung with a bronchoscope and take the peanut out. So people can have a diagnosis that mimics asthma but may not be asthma. You got to be careful.
Is asthma connected with other illnesses, or can asthma lead to other illnesses?
So asthma is clearly associated with allergies. So there's a very, very strong association of like sinus, hay fever with asthma. But if somebody has chronic asthma, in terms of leading to other problems, it mainly can lead to other kinds of lung issues, and sometimes where their lung function, if they're not under good control, their lung function could almost continue to be obstructed. And we call it a fixed obstruction. It's not very common when the patient's treated properly, but if they're not treated properly, and let's say there's continued smoking or something like that, it could lead to a chronic lung disease or chronic obstructive pulmonary disease. So really, we've seen that mainly in people who are continuing to be exposed to smoke in spite of the fact that we may tell them not to smoke.
And Dr. Fineman, there's this medical term, status asthmaticus. Would you please tell us about that?
So status asthmaticus is a definition of somebody who has asthma who's in so much difficulty. In other words, their air tubes are so closed down that they're having a lot of trouble breathing. And those are the patients that used to be hospitalized because they needed oxygen. We had to give them extra oxygen. Fortunately, we haven't seen that much problem with status asthmaticus recently because we've got good medications to help control them, like the inhaled steroids. But status asthmaticus is a very severe, potentially life-threatening condition where the tubes can close down and patients need oxygen. So asthma is not without, asthma is certainly a very serious condition. It could lead to as status asthmaticus or even potentially a lethal or a morbid or type of condition if it's not treated properly. But if it is treated properly, it's really can be managed and people can lead normal lifestyles. So I think the goal of patients is to make sure they go to a physician specialist who can manage their asthma, make sure they control their lifestyle and control their medication, have a good treatment plan. We call it an asthma management plan, a good asthma treatment plan, so that they can lead a normal lifestyle. And I think that's the main goal.
So we're here with the allergy specialist, Dr. Fineman. Dr. Fineman, I'd like to ask about people who are participating in sports and asthma. That's a huge field. Would you say a few comments about that?
Well, exercise is one of the main triggers for asthma. So what we see is in patients who have asthma, frequently they have difficulty with exercise. And this can be an elite athlete. We see Olympians who have trouble with asthma, and we see the average weekend athlete also having trouble with asthma. So it really varies, but it can always trigger asthma. And it has to do with the physiology, their lung function. When you exercise, you start breathing more rapidly. And when you start breathing more rapidly, you really push the lungs, more. And when you do that, you're more likely to get symptoms of asthma if you have asthma. So people who exercise, you're going to get a little more short of breath because you're working harder. But if you have asthma, then it can trigger your air tubes to close down. This is your airway obstruction that we talked about with asthma. So exercise can do that in an asthmatic patient. That's where medications come in for that.
And Dr. Feynman, would you give us an example of a case of an asthma patient that can give us hope, who had a difficult circumstance and was treated and responded?
Well, fortunately for patients who have asthma, we've got some very, very good therapies. Patients do respond to bronchodilators. The inhaled steroids that we have available are excellent medications. When I started in practice over 30 years ago, we used to see people in the hospital because their asthma wasn't controlled, and they have to go in the hospital to get better because we didn't have a lot of good tools to give them, a lot of good medications. Now we've had excellent medications that can really help patients. The inhaled steroids are very good medications, and they really have kept patients out of the hospital. I mean, quite frankly, I haven't been in a hospital to see one of my patients with asthma in years. So it's a very, very positive thing for patients. The other thing that's kind of interesting, I had a patient about a month ago who was a child, he was a teenager, and he was on his school football team. And he was very good at it. He was a good athlete. And he was having some trouble with his breathing, but he didn't think that much about it. He came in, we did lung functions on him, and it was interesting that even though he was an athlete, his lung function wasn't very good. And then we gave him bronchodilator, and we treated him with inhaled steroids. His lung function improved dramatically. And not only that, he was able to run, and he scored several touchdowns in a game because he was able to perform so much better since he was treated and recognized as having asthma. So it's really important if you're having the symptoms of breathing difficulty, of the coughing, of the wheezing, or recurrent respiratory illnesses, to make sure you get evaluated to see if you might have asthma, because it's more common than you think. We see, in fact, in children, it can be as common as 25 to 40% of children may have problems with asthma at some point in time. In adults, it's not quite so common. We usually see about between 7 and 9% of adults. So it's still, that's a lot of people.
We have been speaking with Dr. Feynman about the aspects of diagnosis and treatment of asthma. And the final question, Dr. Feynman, would you please tell us about any new research in the field of asthma?
So we've been really fortunate in that recently we've understood more about the mechanism of the inflammation, or the mechanism of what triggers the inflammation which is causing the asthma symptoms. And what we're finding now is that new medications are being developed, that we call those biologicals, that are targeting the different mechanisms that trigger the asthma inflammation. So what we'll see in the next few years is various medications. We call them biologics because most of them are biologically based, and usually given by some type of injection, either IV or a shot. And what they do is they target the inflammatory factors that cause the air tubes to close down. So these are targeted therapies. They should be very effective. They may not be for everybody, but for some of these more severe, moderate to severe type asthma, it shows a lot of promise for these patients.
How long before we see that actually available at the bedside or in the clinics, these medicines?
So some of these medicines are available now. We have several have been approved in the United States that we've started to use. And I think in the next few years we'll probably see more. You know, the real tricky thing is to figure out which patients respond best to which of these new therapies, the new biologics, because they are fairly expensive, and you want to make sure you target the patient properly. So these are targeted therapies that target certain inflammatory mechanisms, and then we have to figure out which patients are the best ones to put on the medication. So there's a lot of hope for asthmatic patients.
We are here with Dr. Feynman at an international conference in Jerusalem. Dr. Feynman, would you please give a few comments about this conference?
Well, the World Allergy Organization is really an organization made up of a number, almost 90 independent societies, and the societies are around the world. There's societies in the United States, there's societies in Europe, in Asia, South America, Africa, every single continent, in Australia, every single continent, we have representatives from all over the world here, and the organization is called the World Allergy Organization. We promote allergy treatment and allergy diagnosis for allergy patients worldwide. And obviously, it's a challenge in certain places. Some places don't have the same medical care access that other places do, but we try to elevate the needs of the allergy patient with the World Allergy Organization. Now, I'm a little biased because I'm on the board of the World Allergy Organization right now, so I'm in the leadership, but we really fulfill this mission of reaching out to all the countries in the world and trying to help improve the care of their allergy patients.
So Dr. Feynman, I'd like to ask about the aspects of alternative medicine and complementary medicine regarding asthma.
The field of alternative medicine and complementary medicine is growing, and we know that. One of the challenges that we have as allergists is that we treat our patients in a evidence-based manner. What that means is when you have an evidence-based treatment, that means that the treatment has been studied in a placebo-controlled condition. So some of the patients get the treatment, some of the patients get a placebo, and then you evaluate how the patients respond to that treatment. And one of the problems we have with alternative therapy is that we don't have a lot of good studies with the scientifically done placebo-controlled trial with the alternative type treatments. Now, I know they're becoming popular, and I have a number of patients who are using them, but we don't prescribe alternative medication for asthma because we don't have good quality evidence-based studies documenting the response to it.
So we would like to thank Dr. Stanley Feynman, allergy specialist, for speaking with us. Thank you, Dr. Feynman.
Thank you. Thanks for having me.